Good evening, welcome to tonight's webinar. I'm going to hand over to Dr. Nkube. Dr. Nkube, over to you.
Good evening and welcome to the third edition of our policy dialogues, where we will be discussing community service and rural allowances. In the previous two webinars, we discussed commuted overtime, of course, in the context of the working hours for doctors in the public sector. And we heard from several of our panelists how overtime will always have a place in our healthcare system as long as we continue with the current shortage of healthcare workers. And also that there is a lot of planning that needs to be done in order to improve on the availability of our healthcare workforce to serve the needs of the country. During that time, we also had conversations about the large number of hours that are worked by several doctors, including some of the doctors who were in our audience asking if there is a way to cap the number of hours that doctors are working. All in all, there were two views, some that said the overtime is excessive, and others that said, well, the overtime is needed and needs to continue at least as is. And the majority, of course, of the doctors say to us, there is a fair distribution of working hours, at least where they work. We then went on to, and also Department of Health did invite us as SAMAE to provide input into the Human Resources for Health strategy, and as well as the Ministerial Advisory Committee as and when that request is made. We then moved on to discuss RWOPS, which was another interesting topic for the day. We discussed that RWOPS is a legislated activity and needs to be looked at in that context. There was an acknowledgement that there's challenges in the governance and management of RWOPS, both from individuals as well as from management. Several proposals were made, including encouraging private-public partnerships to enhance skills development through RWOPS. There were also discussions and suggestions about ensuring that the hospitals are well equipped so that the doctors are able to continue providing services throughout the day, as some of them had to stop working and eventually go into RWOPS because the hospitals were ill-equipped. So those are some of the things that we've discussed previously. And today, we have a very impressive panel yet again. We have Prof. Machiza, who is a professor at the University of Free State, and he's been running a program to alleviate the challenges of surgical backlogs in Limpopo. We also have Dr. Safika Mbangata, who is the chairperson of the Rural Doctors Association. Along with her is Ms. Thabisa Tsagaza, who is the chairperson of the Rural Nursing Association of South Africa. And we also have Dr. Senzo Nkosi, who is a general practitioner and has spent his entire career working in rural hospitals in Mpumalanga. And so we will start off with a presentation from Prof. Machiza, who will share with us the work that he has been doing in Limpopo. I will share his slides and we'll be controlling them. Thank you.
Good afternoon, evening, everyone. As Dr. Nkube has said, we've been doing some work for a while now. From 2017, we've been doing this work. Just a background, when it started, it was a request from the then MEC of Health, because she only had 2 orthopedic surgeons for about 6 million people. And definitely, so it was 1 orthopedic surgeon at the main center, tertiary hospital, and then 1 at a regional hospital. So we agreed to help, started as a very small thing. The first time we were 4, so up to current, where when we go, we usually have numbers up to 30. So you can move to the next slide, Doctor. Sorry, I couldn't share from my side because I was driving. I was grabbed. So this is just a map of South Africa. I hadn't done this presentation in India. I was asked to come and present it. So it was just to show. So next one. So this just, I was just trying to illustrate that I'm based in Bloemfontein, which is about 1,000 kilometers to where we are doing this outreach. So the logistics are covered by the Department of Health there. Okay, next one. So I think you can, in Polokwane, that's where the tertiary hospital is. That's so the end, it's got 5 districts that have to refer, if I can pull it, tertiary cases. So those are just the people there. We can skip that one. These are happy people. These are human beings like us. You can see them dressed in their traditional gear. And now we got 2 problems there. The whole of South Africa, actually. It's not, we can say issues, not problems. One is the amount of trauma, the trauma overload that we get. The nature of our society is violent, alcohol, drinking, and then also that people are living longer. So in one spectrum is trauma, and on the other side is people now getting older now with degenerative diseases that needs joint replacement and so on. When can move next one. So I'm gonna try and rush through this. Can put the next one so that we don't deviate mostly from. So I mentioned about the 5 districts there. So I've put it there to show that in those 5 districts, we do this outreach. It rotates in those. So it's monthly now. We were in Sekhukhune last month. Now we are going to the Capricorn district. So the team moves around. We go where there's a need. So there's no need for all those patients to go to Pietersburg because Pietersburg Hospital doesn't have the capacity to house those patients. And these patients have nowhere to go. Pretoria, there are 3 medical schools and the central hospitals, but they've got their own challenges. The backlogs are as long as anywhere else. So they can't cope despite the fact that they've got a lot of skilled. So these patients are just basically sit there in these areas. They can't go anywhere. So that's the need to go and assist this population of patients. The next one. So I've mentioned how it started. Limpopo is a rural province, like it's mainly rural, like Northwest Province, the Eastern Cape, Northern Cape. So it's very difficult for them to attract specialists to stay there. Young people especially, they want to stay in metropolitan areas. So they've got a large backlog, as I mentioned, and we're holding it monthly. When we started, we used to do it quarterly. We'll just choose hospitals, and I think the largest when that period we did was 7 theaters working over 2 weekends, and I think a record of about 100 patients were done on those seven theaters. So, as I mentioned, it used to be started from specialists outside the province, but now the local specialists take part, and it has now. What happened? The benefit of this is that other departments, other specialties, started complaining in a good way that why is it only orthopedics that's doing it? So now you've got different specialties: maxillofacial, ophthalmology, gynae, general surgery, you name it. They now take part in this initiative. It now starts on a Monday and end on a Sunday. Because we're employed elsewhere, we're still going over the weekend. But you'll find that during the week, the local specialist there would have started on a Monday. So it has been beneficial. Okay, next one. So the planning, the logistics, the traveling, the accommodation is covered by the Department of Health, local Department of Health. So we designed a preparation checklist for each hospital when we go there. So it will be like general checklists, things like food, surgical ward space, duty rosters, and then equipment. It's just an example there. We need orthopedic machines like C-arm or orthopedic traction tables. Your suction autoclave must be working, and theater also. The tick box that this list, they go through it to make sure that everything is sorted. And human resources is very critical. You need everyone there. We need everyone on board. Porters, cleaners, if they are not there, this thing won't work. The allied health, they have to initiate your rehabilitation. And then pharmacy has to supply the consumables. And then the list is prepared by, I'll come back to this, is prepared by a doctor. From our side, we call that one an anchor doctor. And it has happened many times that you find that it's a community service doctor who's working in orthopedic ward. So this is the doctor who will prepare a list, we communicate with that doctor, and then we exchange x-rays and then plan accordingly. Obviously, the infrastructure, you need to have water and so on, generator in case you don't have you have electricity problem. The next one. So I won't go through this, but if you can just see the departments that are taking part at the moment: pediatric surgery, plastic surgery, radiology, urology, ENT, general surgery, gynae, maxillofacial, ophthalmology. And this is biased towards orthopedics because we started first. That's the first thing. And secondly, we make sure that we collecting that data ourselves. So that may be skewed. For example, ophthalmology has done more cases. Cataract extraction surgery has been. They've done more cases than anybody else. Next one. Yeah, so I won't spend a lot of time. Just to say to you, those hospitals there that you're looking there, those are district hospitals, except Litaba, Mankweng, and Philadelphia, Mukopane. and Pietersburg. The rest are district hospitals. That some of these procedures, according to the government gazette, they're not supposed to do those procedures, but with the outreach, we take the services there. So we have succeeded, and we've done operations that we thought generally it was not safe to do, and there have been articles published supporting us that, for example, joint replacements can safely be done in a district hospital. There was a paper, South African paper, published in Cape Town by the team there. Next one. So this is just the total number of surgery, as I mentioned before, plastic surgery coming in there as well, and the other departments that I mentioned. So this is just the list that shows 2017. This was still only orthopedics at that time, and then up to present. But this is where we have we could collect reasonable data up to 2022. Next slide. So there it was this is just to show that, and which we have improved on now, data was not captured well. So you end up with a lot of cases that you didn't know whether it was left or right. This is just something to look at to improve. This is what we could gather from the data we have. Okay, next one. This is just normal demographics by sex, male or female. Next one. So we operated patients up to the ages of 80, more than 80 years old. So this just shows that you could cover all ages, basically. I think the pediatric ones are basically by pediatric surgery. And if those who have gone surgery in the older age, usually will be your fragility fractures, like neck or femur fractures. Next one. Okay, I think we can also skip this one. It's just all the same thing. So I'm an orthopedic surgeon, so this is the bias of orthopedic patients. We can skip this one as well. So this is just a graph showing you that comparing orthopedics via other specialties, and also the number of patients, the highest, the age group between 41 and 65. So the graphs closely follow each other, except when you come between about 20 to about 65 years. Obviously here you've got pediatric surgery that will probably skew your graphs and so on. Next one. So we can move this one. So as I mentioned, we have operated older patients, 89 years and so on. The oldest was 89, the youngest 1 year old. So this is just a list of all the operations that were done by this combined. So you can see there from hysterectomies, ultrasounds, also the radiologist doing CT scans, lens cataract. As I mentioned, you can see that the cataracts are this got the highest number here. These are just non-orthopedic patients. Okay, next one. So in orthopedics, it's the usual thing there. So the operations that normally people will say are not done. Look at the total hip arthroplasties that were done. This is at that time it was 82 patients, and these patients would have been on a waiting list in Steve Biko or Baragwanath or George Mukari. So, but we did them. The hemiarthroplasty is the knee replacement. So we show that this could safely be done as well. Next. So just example, this is patient who had polytrauma. You can see the femur was broken, the tibia was broken. So this patient would have been waiting on the in the hospital bed. We found patients when we started who have been waiting with double fractures like this for 6 months, because when they refer them to the nearest tertiary center, they will tell them where they are full. This is the patient who had 2 ankle fractures, the tibia and the fibula there, who had a knee, tibia and a femur. So this is a polytrauma patient that was helped by this initiative. Next one. So this is
Prof, you muted.
okay. All right. Yeah, is it fine now?
Yeah, we can hear you now. Thank you.
Yeah. So this is a complex surgery that will normally be reserved and be done in tertiary or quaternary hospital. But this patient will go nowhere because they have many of these cases waiting. Just giving an example here that we're even doing complex surgeries there. Next one. There are a few things, as a case study, we know of at least 10 MOs who were part of this outreach that are now orthopedic registrars. The number has gone, and then we're working on the publication. We started with only 2 orthopedic consultants in that province, and when we started, I was the only consultant and 3 senior registrars. At the moment now, you'll find there are at least what we'll call a core 8 regular participants, and supernumerary registrars getting experience. They work under our supervision. You scrap with them, and then there were new projects that they start the male circumcision, and what we did was to make Limpopo attractive to specialists. At one stage, it had 12 specialists, and with at least a quarter of them having been part of the outreach. So the province got exposure, and we also had a surprise visit at one stage from the president. Acknowledging the kind of work that we are doing. Next one. So as a few articles in the newspapers that reported on this. Next one. So what I wanted, if I want to take it to the topic of discussion for today, if you look, those are rural hospitals. I know of at least 3 district hospitals that the orthopedics is done by a medical officer who is very good, who can do some of the procedures. And when we go there, we also upskill those medical officers. So they are staying there in the rural area. And I'm certain that Rural Allowance is playing a part. They've made those places their homes. These are elderly people. And even the community service doctors, some wards you find that are managed by community doctors. There's no one managing that ward, so we exchange, as I said, the numbers, and even when we have left. Sorry about that. Even when we have left, we still have contacts with those doctors. So if they have a case, for example, even if we are not there in that hospital, they will contact one of us for advice. So they have direct specialist advice, which has helped a lot. And then so in my view, community service has helped a lot, as I mentioned. And the Rural Allowance has kept some of those doctors in there. So if we take that away, I'm sure those doctors who are there, if they get jobs somewhere, they will move, because there's nothing really that is keeping them. And we have shown that some of these procedures, because we read the first world literature that tells you the theater must be like this and this, and we have shown that these procedures can safely be done. And we have a follow-up through those anchor doctors. They'll tell us if there's a problem, something that didn't go right, they will inform us. And just for the record, I have gone, because complications occur, I have gone maybe about, in the last 10 years, maybe about 5 times to sort out a complication that occurred. So that is the one of the conditions that we agreed with the government, that this is surgery, complications do occur, and if they occur, you must be prepared to put me on a flight the next day or two, which they have happily done. It's not a problem. And so we are joined by people from SMU, Sfakomagatu, Vets, University of Pretoria, and of course where I am at the University of the Free State. And we've had a fellow who used to come from Walter Sisulu University. This is just has stopped now for other reasons. So, and the thing is that also what it has shown is the goodwill and the good hearts of South African people. We are going next weekend, and we have now we have a problem. There are 28 people who have registered to come, and we're only going to be offered 4 theaters. So we've decided to divide. One group will go one weekend and the other one the following weekend. So if you ask me, with through this experience that we have had, Rural Allowance should stay, community service should stay, because it's helping man those rural hospitals that people do not want to go and work. Thank you. I think I can answer questions as we go.
Thank you so much, Prof. That's very inspirational work, and there's lots of clapping of hands that's coming from our doctors. I think I'll start with our panelists if they have any questions and comments. Starting with you, Dr. Nkosi, do you have any questions or comments for Prof. Machiza?
Firstly, I would like to say it's wonderful, quite commendable. It's very encouraging to see that even within our profession, we still have people that are willing to go the extra mile. And I think it's also commendable the type of assistance that the government has also put in, which goes to show that if all the things that are put in place are pulling in one direction, there's a huge chance for success. I don't think with the type of presentation that we've had from Prof that I would have any questions, but to say congratulations for the work done. And I think I'm quite jealous because Limpopo is just next to Mpumalanga, you know. So I'm just waiting that moment when they come through to our province, but it's quite good what they're doing.
Yes, if I may say, we have had invitations to come and assist in Mpumalanga, but it never materialized. We have a meeting with the Eastern Cape government and through SAMA as well, that we're going to have a first meeting to see how this can be extended to the Eastern Cape. So there are willing hearts that are willing to sacrifice their weekends, and this is that maybe it didn't come out. This is voluntary. It's pro bono. We don't get money for it. So we just do sacrifice one weekend to go and assist the very people that can't afford our services.
Okay, thank you so much, Prof. And there you have it, Dr. Nkosi. Yeah, you can keep talking to the guys in Mpumalanga. The Prof is willing to come. And then Ms. Zagaza, your take on the presentation? Oh, you're muted.
Can we hear me now?
Yes, we can.
Okay, thank you very much, Prof. I will start by saying a job well done. And I wanted to check, are you doing this outreach as a locum? Because I think you are employed elsewhere, like as you said, so you are doing as a locum.
No, this is voluntary work. That's why we do it during weekends. Orthopedic surgeons coming from outside, we only go there. We leave on Friday, last flight after work, and then we drive to wherever we're going, which district we're going, and then if I can, then the rest who are closer, like Gauteng, they'll go back to their stations on Sunday, and then from Bloemfontein, they put us at the airport. 6 o'clock first flight in the morning, we are out. So by 7:30, we're at work like anybody else. We don't get paid for this.
Okay, so for now, your focus is around that province. So any plans of expanding this initiative to other provinces as well?
Yes, as I mentioned, we are going to have a online meeting with the HOD of Health at the Eastern Cape. The meeting was actually planned for today. I had to postpone it because I was hijacked to be in the exam. There were some examiners didn't pitch up, so we're supposed to have this meeting today to start. They are ready. I think they are eager and ready, and they wanted to see how they need to come in. You need the support of the government here, as I mentioned. They need the logistics. They must make sure the hospitals and so on are ready. So Eastern Cape Probably next time when we present, maybe we'll be presenting statistics from the Eastern Cape. Mpumalanga showed interest, but then there were changes of leadership and just fizzled out. There was one of the participant comes from Zirats in the Northwest, and he was saying who can help him set it up in Northwest, and he said by all means. And as I mentioned, we are 28 now. You can imagine if we could get 10 theaters, how much work we will do. We're getting more people than we can accommodate. So yes, we can expand to other provinces.
Thank you. Then the last one, do you know a secret of keeping people of Limpopo to such an age, to above 80? Is
Well,
perhaps healthy lifestyle or what?
you know, I wouldn't, but my guess will be people who still live off the soil, you know, the people of Limpopo, because of the fertile land, they still eat organic food, and most of this older generation, they still farm, they still do farming in where they are in their homes, what we call subsistence farming, not for profit. So I think they keep themselves fit up. That's probably what I would ascribe the long life to that. Yeah, that's my guess. I don't think it has been proven.
So as part of human resource, when you go there, so if I say perhaps we need you this side, so the HR, other aspects of HR is catered for by us, the hosting in hospital, like in terms of the nurses and other categories.
Yes. So there's a checklist there that I showed you that we prepared just to make sure. So it's called human resources. So either you must pay the staff overtime for that period you are coming, or give them offs so that they are available for the outreach. So that's the HR process, yes. And sometimes what they do, they will borrow nurses from other hospitals for that weekend. And I can tell you, some of these nurses are trained in theater, but because of the hospital, they're in a district hospital. The only thing that they are doing there is no appendectomy and cesarean sections. So when you come in there and do procedures that they were partly trained in, they're very excited to be part of it. I think that's one thing maybe that keeps this thing alive.
Thanks so much.
Okay.
Thank you. Thank you so much. And Dr. Mbangata, any questions for comments?
Thank you so much for this opportunity. First of all, Dr. Ngobe for organizing this webinar, and for Prof. Machitsa for this wonderful presentation. I think we can all attest to the wonderful work that you are doing in Limpopo, and of course in the Free State province as well. Thank you so much for that. I think the work that you are doing talks to exactly what the government was aiming to achieve when they made the amendment in 1998 of introducing the community service program. So number one, to improve the health services in South Africa, and to also upskill or create a conducive environment of leadership amongst the community service doctors for them to be independent practitioners who are able to, take critical decision making in clinical practice. And then I also was very touched by what you mentioned about patients who experience polytrauma but find themselves in hospital for up to 6 months. So this talks to the crisis that we are currently facing in our country. The fact that we cannot now do away with, this one critical aspect that is serving in the rural communities. So doing away with community service will really be a disservice to patients who are already in critical need of, your skills, services of community health workers and healthcare professionals generally. I think if a polytrauma patient can wait for that long, it only begs the question, how much more for patients who may not be seen as emergencies? So this really is a crisis, and I think that doing away with community service is really not a great move at this point in time for our healthcare system. That's just my comment. And one more time, Prof, well done and congratulations on the amazing work that you are doing.
Oh, thank you.
Thank you, Dr. Mbangata. I think I'll direct my first question at Dr. Nkosi. So Dr. Nkosi seems to be the one doctor who spent quite a lot of time in rural health and perhaps quite closer to his community service. So what were your experiences in your community service, Dr. Nkosi, in terms of development of your clinical skills, as well as whether or not you felt you were making a difference in the community that you serve?
Well, firstly, I think what's important is to understand the context of community service. I think that year sort of like puts everything into perspective, from medical school through internship, and then the community service year sort of like brings it all together. I did my ComServe in a very rural hospital, BT Hospital in Mpumalanga, by the 3 roundabouts, don't travel. It's a very small hospital, very much secluded, quite far away almost from everything. But I think the essence of that is to try and show you the limitations in the health system and how we as the upcoming doctors can help influence that. There are certain things that you're going to learn, certain skills, certain ways of doing things that you're going to be exposed to by being in those hospitals that you won't necessarily get in your tertiary or regional hospitals. There are limitations, yes, of course. There are things that you may not have access to. For example, our referral hospital, when I do my ComServe, was 2 hours away. Sort of makes life a bit difficult, especially with the issues of EMS and all of that. But then that brings in another chapter. You are there with the patient. You need to help the patient while the patient is with you. And I think for me, it came in twofold. With my internship, I did it in a semi-rural hospital. I did my internship in Thohoyandou, Chiridzino Hospital. It's a regional hospital, but quite deep in the rural areas. That's, I think, for me, the essence of having a community service here is to actually go back into the community and serve the community. Hence, the approach to have most of ComServe placed in the rural areas is essential, because there are things that you will learn in clinical medicine that you will have to apply differently when you're faced with those situations. You might have a patient that will ultimately need ICU, but for the patient to be able to reach ICU at Rob Ferreira Hospital, 3 or 4 hours away from the hospital, you as the ComServe doctor have to now put everything that you were trained in medical school, your whole training during internship, put it together and be able to manage that patient. So it will have certain skills, and it gives you that sense of dependence where you know that you are the one that has to take the critical decision that Dr. Mbangata just spoke about, to say, I need to make sure that this patient stays alive. Now, when you are in a tertiary hospital, as a junior doctor, you always look to your seniors to say, even if this does not go right, even if the resource doesn't go right, I won't be the one that has to account. I won't have to write the patient safety report and all of those things. But now that's the platform that community service gives you, and it makes sense. After community service, you can now be told that you are an independent practitioner because you've gone through all the training that is necessary. And the last thing is, I think for our setting in South medicine in South Africa is quite different from the first world. Now, to do away with community service, I think it will be creating a huge gap in terms of the actual needs of our community. Because now, when you look at the work that is done by people, Prof. Machida, for an example, the rural areas are the most impoverished. They lack most of the necessary services. Now, by taking services to the rural areas, we actually empowering the people that need these services. So without the community service here, it's going to be very, very difficult to see how the hospitals in the peripheries are going to attract clinicians and not actually. So I think it is an essential gap to have in our team as medical doctors, especially in the context of medicine.
Thank you so much. Thank you so much, Dr. Nkosi. And Ms. Tagaza, how helpful have the community service doctors been to the nurses that you work with?
Thank you, Doc. As Dr. Senzo has mentioned, they are the ones who are taking decisions, and they are so helpful to assist us as nurses. Because in terms of the referral pattern, you'll find that the referral institution is very far away, miles away from the workplace where you are. And in terms of the turnaround time and the ambulance delays, you have to take decisions. So we are solely dependent on these concept doctors. They are playing a pivotal role in nurses' lives. Thank you.
Oh, thank you. Thank you so much. And Dr. Mbangata, you've released, I think, as part of RDASA, you've managed to write up a policy brief on community service following the discussions that happened in Parliament. So I think part of the discussions are around converting the community service positions into grade 1 medical officers directly. How practical do you think such a proposal is, and what would be the impact of that?
Thank you for that question. So I think one thing we need to bear in mind is that at the current state of our health, that does not look like it would be a practical approach. Number one, we are looking at a scenario where we have unemployed medical officers. As soon as you're done with your community service, you have a situation where there are doctors who are independent but cannot secure employment in government. Now, government has converted that crisis into saying it's an oversupply of doctors, which is not necessarily the case, because when we look at the doctor to patient ratio, we are not where the World Health Organization recommends. So we're sitting at 1 doctor is to 3,100 patients, which is not practical. And in our context, it's really not sustainable. And so if we're saying that we're going to do away with community service and convert it into medical officer posts, do we have the funding for that? Because we are looking at a more long-term solution that is also not a security measure, or how can I say, not convincing enough, looking at the context that we are finding ourselves in. So it would mean that we would have to have a phased approach to implementing that, and not completely doing away with community service as an abrupt solution, because community service doctors, rehab, healthcare professionals all play a pivotal role in supplying services to rural communities. When you look at, for example, the rehab healthcare professionals, 27% of them are the ones upholding the rural communities. And when you're looking at the mental health aspect, 64% of patients who are in rural communities do not have a psychologist that they can call upon. So meaning there's still a huge shortage, and this shortage is supplemented through the community service doctors. And so we would need to look at, those possibilities and those facts that are underpinning the decisions that the government took back in 1998 to where we are finding ourselves today. So I don't think that it would need to be abruptly implemented. We need to ensure that we would be able to not create a gap where the community service was actually covering us. So yeah, those are things that need to be taken into consideration.
Thank you so much, Dr. Mbangata. And Prof. Machitsa, what do you think about that conversion of community service doctors to MO positions?
Yes, I think they used to do it initially when before this crisis we're having. Most community service doctors where we were going, they ended up as medical officers. And this the community service doctors I mentioned earlier, these are the ones that are we're communicating with. This is the ones that prepare the patients for us. They look after those patients. So they play a very pivotal role. We can't do without them. It's just as simple as that. I just wish we could convert all of them, those medical officers, especially in rural areas, into medical officers posts. That will go a long way towards addressing. And as she mentioned here, there's still a large shortage of doctors. Our ratios are not right. It's no oversupply. And they were asked, they were in forums where the government were asked by some deans that if you're saying there's no employment opportunities for doctors, should we stop training doctors? And the answer was no, don't stop training doctors. We still need them. They just need to get their funding right.
Okay. Oh, thank you so much, Prof. Thank you so much. Senzo, you see, I went to school with Senzo, so now I forget at times that it's the campus. So may I be allowed to stick to what I know? Yes, so Dr. Nkosi, post your ComServe, you have remained in rural Mpumalanga. How did community service play a role in your decision or your colleagues' decisions to actually stay in that rural setup?
Yeah. Look, it would be very impractical to say a rule. Firstly, like you're saying, we went to the same school. So in UKZN, what they do in final year is that they send us very far from campus to do a family medicine rotation. I remember I was at Mseleni Hospital, very far in northern KZN, and I think that's the first exposure I got. And we were living with the families in and around there. They did not book a hotel for us or anything. just to try and get you to experience how it feels like to be part of it. And like I said, when I went for my internship, it was a similar setup. So now when you spend a bit of time in those areas, you get to realize the need for actual medicine, the way in which medicine is practiced when we go out into the tertiary areas, which are mostly in the urban areas. So now, to directly answer that question, you have to have the love for rural medicine, simply because I think I've touched on it to say there's very little for clinicians to hold on to except the monetary incentives that the government offers in terms of rural allowance. But I think you get to a point where you realize the gap that Dr. Mbangata was talking about, to say there's an actual gap that exists in the rural areas for clinicians. And some of us want to go in and fill that gap. You will get those of us that feel that staying in rural medicine limits your growth as a clinician. You're going to be an MO, they call them O's, you're not going to go into specializing and everything like that. But it depends on what a person wants to achieve, essentially. I feel there's still a lot that can be achieved even when you're doing rural medicine. For an example, right now I'm part of the National Malaria Setup. There's a lot of things that I'm involving myself in. So being in rural medicine does not move you away from opportunities to grow in the medical field. It actually exposes you to a whole lot of things that can help you grow. So I think if we remove that year of community service, we are then now removing the exposure for some people who would want to remain after they've been exposed. Now, that then means that everyone would want to go and work in a regional hospital. Everyone would want to go and work in a tertiary hospital. And it becomes even worse when you now start talking about removing rural allowance, because now what else are you going to use to keep the doctors in the rural areas? So simple answer to your question is yes. Rural medicine did play a part in me deciding to say, you know what, let me stay here and serve the people. But at the same time, it has not limited my career in any way, because I feel and I know that there's been growth in terms of the career. So I don't think it should be seen as a limitation to say when you stay in the rural areas, you'll be limited. For example, where I did my internship, my concept, and where I'm currently working, I think 40% of the staff in Barberton Hospital, where I currently work, is community service medical doctors. Now, you remove those people, then you suddenly your system is crashing. You don't have enough doctors to be able to do the work that's needed on the ground. So, and I think even for them, being in that setup, it's a confidence builder. It helps them to say, I can go into theater and actually be the one that cuts a cesarean section, not to cut it as a form of a list that I need to complete for me to be signed off for my ONG rotation. So I think we do need the year of exposure so that people can be given the same opportunities we got to decide whether rural medicine is for them or rural medicine is not for them. But essentially, having that rotation, it works well.
Well, thank you. Thank you, Dr. Nkos. You mentioned something about rural allowance. How much does rural allowance play a role in some of your colleagues hanging out there in rural medicine?
Look, I'm not going to lie. Again, you mentioned that both in school together. Even when we applied for internship, when we were looking at, for an example, when you compare Prince Mchieni against Chatsworth, RK Khan in Durban, everyone would want to go work at Prince Mchieni, even though there's more work compared to RK Khan. But Prince Mchieni is rural allowance, last I checked, and RK Khan did not have allowance. So essentially, having rural allowance, whether internship, ComServe, or post-ComServe and internship, it does play a huge role. For me, it's the only incentive that so far I can say can be used to convince clinicians to stay in the rural areas. Because otherwise, if I am going to Matibiti Hospital is 2 hours away from Haskop, where you have maybe Spar and ShopRite. It is 4 hours away from Nelspruit, where you're going to get to go watch a movie and everything like that, you know. The nearest filling station, when you're working in Mativiti Hospital, the nearest decent filling station is 2 hours away. So you can imagine the administration that comes with that. So, you know, when you're traveling, you need to get a full tank so that you can be able to move around. So now, if you're going to offer me the same pay that you're offering someone that's working in Rob Ferreira Hospital, and I have all of these things to deal with, then I'd rather work in Rob Ferreira Hospital where a filling station is just 30 seconds. You understand? So I think the rural allowance is probably the most important when it comes to keeping clinicians in the rural setup.
Thank you so much, Dr. Nkosi. And Dr. Banata, do you agree?
I strongly agree with Dr. Nkosi. I would also go on to add that there also has to be personal incentives. There has to be, you know, professional incentives, because being far removed from what is deemed as infrastructural development, what would be deemed as academic support, etc., and isolated in a rural facility somewhere there, it really takes a lot of commitment and passion for, you know, clinicians to commit to working there, and that has to be, you know, met with, you know, equal compensation for that sacrifice. Because, you know, if you are a married woman, for example, working in a rural facility, where are your children going to study? It means you need to now take them to boarding school. You're being separated from your family. You know, you have to consider those kinds of things, and you need to meet the healthcare professionals halfway. And I think it also takes me to a discussion that we may have had informally, you know, of this platform, that, you know, working in a rural facility, especially one that is underdeveloped in terms of the roads, in terms of infrastructure, it takes a lot. It means your tires need to be, you know, serviced a lot more. You need to get a car that will be suitable for that environment. All of those things need to be taken into account. Whereas if I'm working in an urban facility or in an urban hospital, I don't really have to worry about that. Aldi is just down the street. I can take my car there, and it doesn't matter what car I drive, or whether it's a Picanto or whatever, it's going to carry me. But if I'm working in a rural place where I have to go to clinics and see patients, it needs, you know, the proper support for me to administer those services to the communities that need them. So it definitely needs to be taken into consideration. And it's not necessarily about the money. It's about the practicalities of working in that kind of environment. If the government does not see it as something that is a necessary need, then it means every single facility has to have proper functioning roads, has to have water, it has to have electricity, all of these things that will be able to support working in that environment and supporting why rural allowance is not, you know, indicated in that setup.
Thank you so much. So I think what's coming out of your contribution, Dr. Banata, is that we actually need to be thinking of how the benefits to the rural healthcare workers are actually enhanced rather than you know, the reduction. Yes, and we will really you know, capture that very well when we do our own policy communication.
Sorry.
Miss.
If,
Yes.
I just
Yes, Dr. Nkosi.
one of the
We can't. Oh, okay. We are losing you, so we are losing you. I'm not sure if it's your network. Some statements are not coming out.
Can you hear me now?
Yes, we can.
So I was saying one of the
We lost you again. We lost you again. Maybe you should try logging out and then logging back in. something probably with the mind. And then we'll come back to you. Yes, and Miss Zagaza, does the same apply for the nurses?
Yes, Doc. Much as I want us to be on the same page, but we are having some concerns. I think it's so obvious that initially this initiative was to attract and retain health professionals, the skills. But there is a deprivation that is being done. It is depriving other categories of nurses, as it is only catering for the professional nurses only, this allowance. And again, there is a huge gap in terms of the distribution of this allowance. Much as we are servicing the one, much as our goal is to service the patient, the very same patient that we are servicing, but the professionals that are taking care of that patient, their incentives are not the same. And yet the aim was to retain those professionals. If you can check, for example, the nurses are earning 8% as rural allowance as opposed to 20 to 25%. So we really want this to be retained, but we need some improvement in terms of review the distribution of, it must be standardized. And in terms of nursing, it must cover all the nurses, because it is impacting negatively in terms of patient care. The ones that are not getting the incentive as the rural allowance are not so enthusiastic or keen to service the patients, and they don't have confidence because they are not being recognized. So we really need that to be in place. But other than that, we say rural allowance must be kept as the incentive. As Dr. Mbangata has alluded, not necessarily only to cater in terms of the money, but to check as well the geographical area. If you can make I can make an example. You'll find that a hospital that is in the CBD, like Potchefstroom, nurses that are working there are earning 12% as opposed to the ones that are working in far deep rural areas of Periphala. For instance, Senapolnaris, where they are earning 8%. So you wonder, how was it distributed? And then what were the criteria to implement that? And then to allocate which one to get what? How was it? So we say, as the nurses, we are the ones that are spending the most time. Nurses that are the closest health professionals to the patient, and yet the doctors are earning it, and the other health professionals allied are getting far more than that. The nurse is the one, when the patient is coming to the hospital, she starts with the nurse doing vitals. The vitals that are going to indicate, or that are going to guide the doctor as to give what differential diagnosis. And in the entire average length of stay of that patient, that patient will be staying with the nurse. The doctor will only come to prescribe and to check how is she doing, but the entire stay of the patient is with the nurse. So to curb that frustration, I think we need to review it, but we need it to stay.
Thank you so much, Dr. Ntalaga. Prof. Machiza, you do a lot of work with the doctors in the rural area. And maybe this becomes something that even us as SAMA look up to, and we serve all the doctors in the country, including those that are in the rural area. What support do you think SAMA additional support do you think SAMA could give to our rural members so that they can, at least some of their unique challenges can be alleviated? And Dr. Nkosi, as well as Dr. Bangata, should be ready for that one too. Thank you.
Yes. I think I'm happy to report that the initiative in the Eastern Cape is going to be run by SAMA. The CEO, Dr. Nodikita, has been, we've been talking a few times. They are willing to cover the logistics. I think that was the problem at Mpumalanga, covering the logistics, for example, travel, accommodation, and catering during this. I'm talking more on the outreach, and I think what SAMA can also assist with. We have had private companies wanting to come in and assist in this initiative, but for some reasons they're not happy to give the government money. They will be willing to help to give money to an organization like SAMA, and say SAMA has a foundation for outreach. You'll find a lot of companies willing to donate money. Even hospitals are willing to come in and give in cash or consumables and so on. So there are a lot of companies that if they work through non-governmental organizations like SAMA, they will really support this. And then if it will go well, we start this, the Eastern Cape side that basically will be run by SAMA. It can expand throughout the country. There are a lot of people that want to do this kind of work, as I mentioned earlier. So I think SAMA can play a role. It can take over this and say, we have a rural wing section, a rural outreach section, because as you mentioned, those doctors that are there, community service doctors, medical officers, if they have once in 3 months specialists visiting them and teaching them skills, the community will benefit. They don't have to wait for another 3 months later for the team to come back. So that will also help upskill the local doctors as well in doing some of these procedures that they wouldn't want to touch if they were not taught practically about them. So some can come in that regard. That is, I'm biased more towards outreach. So I think SAMA can come in and take over, lead, and say, for example, if SAMA could talk over, I'm sure we would have started in Mpumalanga, because there were questions about the logistics, the traveling allowances, not allowances, I mean, we fly, especially Bloemfontein, we have to fly. You can't drive and still go and work. The accommodations and so on. The transport from the airport to wherever we are going. These companies will be willing to sponsor. One company just ended up covering a gala dinner at the end of the whole thing. And it's a gala dinner that is sort of people reflecting on what happened, because they will sponsor that, but they're not willing to give money to the government. So there is a big role that SAMA can play here.
Thank you so much, Prof. Dr. Mbangata, what can SAMA do to improve the life of rural doctors and their professional interests?
Okay, SAMA can continue to advocate with other stakeholders. You could collaborate with DASA, with REP, you could collaborate with RURISA and other associations that are for rural communities, for doctors working in rural communities and healthcare professionals in general. I think that the more we all coalesce, our voices will be amplified and our impact will be felt, and policy changes can hopefully take effect. But not only policies, implementation as well, because I think that is what we all seek to achieve at the end of the day. Another thing that I would like for SAMA to consider is to, stratify or put everything into context. Rural communities have about 20 million people, the population there. And when you look at the proportion of doctors that are serving there, it's quite small as opposed to doctors that are working in urban areas. But when you also broaden the scope, doctors who are working in the private sector, you find that 80% of them are all concentrated there, 70%. And then the other 30% is working in the public sector. So that kind of puts into context just how severely and poorly resourced our rural facilities are. So if we could just have these kinds of discussions and implement these policy changes and advocate for these things to be looked at by government, it would really help. But I think the more voices we have on board, the better, because it really will serve to be heard at the end of the day.
Thank you so much, Dr. Nkosi, you had something to say before you left, and would also like to hear from you how you feel SAMA can improve the professional life and personal lives of the doctors in the rural areas. Thank you.
I'm not sure if I'm quite audible now, but I think what I wanted to touch on earlier is something that Dr. Mbangata had spoken about, the issue of personal incentives. I think one of the issues that have been raised with the ComServe here is lack of supervision. One of my clinical managers once said that you become comfortable in doing something wrong that you end up arguing that it's the right thing to do when it's actually wrong, because no one has ever told you that you can't be putting up a C-pop like that, or you can't put up a backslap like that. So your whole life you've been doing it like that, probably been teaching it to the ones that came after you to such an extent that you start arguing that is the right way of doing things. So I think one of the important things that someone needs to look at is the issue of supervision. Train clinicians, you see what Prof is doing is what's necessary. We need more of that. We need more of that in internal medicine. We need more of that in dermatology, in psychiatry, to say, have the people that have the necessary skills go back and impart those skills. It should not be something that Prof has to think of and do out of willingness is hard. It's very commendable, but I think if there was a setup that says maybe every 6 weeks there's a psychiatric consultant that has to go visit the rural areas and train the medical officers that are there on the best management of an aggressive patient, for an example. So I think those are one of the things that can be set up in such a way that you know that the medical officers that are working at Barberton Hospital, for an example, have the right skills, they are sure, and they're teaching the right thing. Such that when your community service medical officers now come and join those medical officers in Barberton, they will be trained on the right thing. Because you can find that you go through your ComServe year without or little supervision, and all you're relying on is making a phone call to a senior friend that you met during internship or someone that you had a good working relationship with. So I think if you can do away with that level of ambiguity and create something solid, it could also help. But I think collaboration is something else that SAMA could look at. Collaborate with other stakeholders to say, this is what needs to be done. Let's not want to do it alone. Let's try and see. Let's go and benchmark and see how other people have been doing it. Let's make community service an actual beneficial year. And I think going back again to what Dr. Mbangata touched on, add more incentives, not just financial incentives, but also academic and social incentives to say, these are the things, like, for an example, there are some of this, like SAMA has partnered with some of these car dealerships and all of those things, add a little bit of incentive to say, we're going to buy tires for doctors that work in the rural areas every 2 years, for an example, if you're a member of SAMA or something like that. I think that it will not just help them stay, but it will make sense to them to say, I'm not just staying here for the money, but there's someone that's actually out there trying to make my stay here better. But more importantly, I think the main focus should be, how do we assist the practitioners in the rural areas to be best at what they do, to offer medical services that are actually at par, not just to offer medical services, because it's one thing to offer a service, but it's another thing to actually offer a proper service. So I think one of the things that we should be aiming for is to say, are we confident in the medical officers that we have in the rural areas, that they are managing the DKA patients as they are supposed to? They are managing the CVA patients as they are supposed to. And I think even peer reviews would also become very helpful in that regard. Have sessions like this, you communicate, you get people that come in to say, we're going to have a webinar on this that is mostly focused on rural doctors, to say, this is the new protocol for hypertension, for an example. You get a lot of patients, still a lot of doctors that still maybe in the rural areas are not good on the latest HIV guide. Practicing medicine in South Africa, not run medicine without the best HIV, you understand? So there has to be mechanisms in place to see if our rural doctors are up to date with the latest. I think that's something that SAMA should be really looking into.
Thank you so much, Dr. Nkose. I think we just have a few minutes left for parting shots. So can we just have one round of parting shots? Just commenting on your final last statement, on your final and last statement on both community service and rural allowance. That what is the take-home message for us? What is that one statement that if we were to put you in our policy position, you would be proud to see? Thank you. Let's start with Prof. Machiza.
Yeah, I think I enjoyed the talk. I've learned a few things there, and the experiences that people have gone through them in the rural area. And it's my strong belief that we shouldn't do away with rural allowances. we shouldn't do away with community service doctors. In fact, I'll go as far as saying there are, and we see it in other departments, where they have motor schemes, the traffic coppers, the engineers. You have a doctor who wakes up every day and go to the different clinics, different areas, and they're using their own cars. And these other departments like agriculture, engineering, they give you get a car that's bought by a government, and then you pay very minimal because they pay part of your salary. And these cars, they are done according to the level of the salaries you are. I had somebody talking about you drive a small car going to some deep rural areas. You'll need a car that will be fit for purpose for that area. It means it will be a bigger car, stronger car. So I will go as far as why is it not extended to the doctors who qualify? We know so-and-so is the one who's doing clinics every day in different areas. So I will say it's something that as SAMA, we should engage the government. And we have doctors like that who could get examples of that. And so that they also get the benefits. Even the nurses, the people that are, they wake up every day, go and give immunization to different areas. And some they're using their own cars. Why can't it be extended to the Department of Health? And rural health allowances should be extended to everybody who's in the rural area. The thing of that, the nurses that don't get the rural area, I think is disturbing, because the very person who gets rural areas, rural allowance, work with those people and all in the same hospital. But other members of the teams don't get it. It needs to go right down to the porter and the cleaner, because they are working at a rural area. That will be my parting shot.
Okay, thank you so much. Ms. Zagaza.
Okay. As nurses are the closest healthcare professionals to the communities they serve, I think they deserve to be treated as such. So rural allowance for all. And the com service nurses are getting this rural allowance, but it must be included in their package, not to get it as a back pay once they have committed stay as their ComServe. So that's our take.
Okay, thank you so much, Ms. Zagaza. Senzo.
I think my remarks would simply be to say, instead of looking at doing away service, we need to upscale it, trying to make it better, make it more profitable for both the employer and the employee. And definitely there is no point or logic in doing away with rural allowance, because it will have a huge impact on retaining clinicians in the rural setup. And I also agree with Ms. Ndagaza to say it makes sense that everyone in the rural hospital should, I think everyone is making an equal sacrifice, and similarly everyone should be equally compensated. But I honestly believe that instead of trying to come up with policy to do away with community service, let's try and come up with a policy to say, how do we make community service better, so that by the time one is said to be an independent practitioner as a medical officer, we are quite sure of their skills and their competency to let them go out, open a practice, go into specialty or something like that. I think that should be the primary focus. And then the rest of these other things will then come into place. Thank you.
Thank you so much. Thank you so much, Dr. Nkosi. And lastly, Dr. Mbangata.
Thank you, Dr. Ncube. I think before I give my parting shots, it's important for me to mention this, taking from what Dr. Nkosi had mentioned earlier. With regards to support and the availability of that, there is a program that RUDASA is running every year for community service doctors called the Onboarding Program. So there are resource packs that are available covering all topics that are relevant for communities in rural facilities. Doctors who are working there, from the emergency department to obstetrics and gynecology to orthopedics. So that is just one of the resources that is available. And that talks to the collaboration that we've been talking about. It's important that we all have that amongst ourselves so that these words can go out there and people can know what support is available, and then we can direct our focus towards, how we can improve it instead of building it from scratch, from the ground up. So my parting shots are the amendment that was enacted in 1998 was to serve two main goals. One, to provide services to rural health facilities that were, at the time, very disadvantaged. And we also need to acknowledge that number two, it was to also upskill doctors to ensure that they are primed for independent practice, they are confident, their leadership skills have been developed. So now we need to go back to the drawing board. Have we achieved that? Are we saying we are now doing away with community service because those goals have been ticked? I think we can all agree that they have not been met, and therefore it wouldn't make sense at this point in time to do away with community service. And we also need to prime medical students, expose them to rural practice whilst they are still at school, and also consider internship exposure as well, so that by the time we get to community service, doctors, allied health professionals are all aware of what to expect, and they are actually looking forward to engaging in those communities and serving there. And when you look at retention, when it comes to retention, doctors that are retained in those facilities, it's mostly doctors who were exposed at one point in time in their lives, whether it was in their internship years, in their undergrad years, or in their community service years. So that means exposure is very important if we really want to cover the gap of the need in rural facilities. And we need to look at that. Universities need to address that. There are universities that are already enacting that, but it needs to be broadened in that respect. And then we will hopefully meet the needs of rural communities. And we also need to ensure that the cornerstone of retaining doctors, which is incentives, is maintained. There's no point in having doctors that are working in those rural facilities already disadvantaged in that they are far removed from society, working in difficult conditions, and now removing the one thing that helps support them staying in those rural areas. So I don't think that it should be done away with. Instead, it should be retained and even addressed further to ensure that there are personal incentives that address security for patients and doctors who are working in those facilities, to address their academic growth, because nobody wants to feel stagnant. Research and development needs to be introduced in those rural facilities. There's so many opportunities for that, and that growth to be entertained. And it also needs to take into account that rural communities also deserve to get services that are of good quality. And to achieve that, we need everybody to come on board. And I thank you for the invitation for tonight.
Thank you. Thank you so much. Thank you, Prof. Machidza. Thank you, Ms. Tavisa Nzagaza. Thank you, Dr. Nkosi. And thank you, Dr. Mbangata. It's been an honor having you as part of this Policy Dialogue. Your insights have been very valuable, and we will indeed be capturing some of them. I'd also like to thank the participants in our audience. We've had some of the members really support some of the things that you have been saying. I can say something for Vivek Lazarus and Jatin Ganda. And also thank you for filling in our poll, which will be critical in ensuring that the voice of the doctors makes it to the Ministerial Advisory Committee. We will also be writing our own policy brief on these issues, and it looks like we will be very much aligned with the rural doctors as well as the rural nurses. So, colleagues, we are 5 minutes past our time. It's been an honor having you, and we look forward to our next policy dialogue that will be discussing OSD. Thank you so much. Have a pleasant evening and goodbye.
Bye.